Hello. Uh, Thank you very much for the introduction, and it's a pleasure for me to be invited to this GIS session. And I have been asked to talk about CFR and IMR, and that'll be, of course, in the context of coronary microvascular dysfunction. My name is Carlols Collet. I'm an interventional cardiologist. I practice in Belgium and now at the Cardiovascular Research Foundation in New York. And with that in mind, I would like to then introduce the topic, perhaps understanding that the coronary circulation is not really what we see in the cath lab, that is only the epicardial vessels, but actually more than 90% of the circulation is composed of the what we call the microcirculation. And there are different ways to assess the function of the circulation, which different techniques. The previous one has been discussed previously, which is basically the use of FFR, resting indexes, and very importantly, the emergence of this pullback-based metrics like the PPG that will basically be redefining the way that we look at coronary artery disease. But when we think about the microcirculation, there are a couple of other metrics that are of importance, and I'm going to specifically focus on CFR and IMR. And we're going to start with CFR. And basically, what you need to understand is that for the muscle to receive more blood, there has to be a reduction in the resistance at the level of the microcirculation. And that is basically the mechanism of blood flow improvement. Reduction in the resistance of the microcirculation basically means making this microcirculation larger, the artery also larger, and by that reduction in resistance, the flow will increase. And that is what we call a normal microcirculation or microvasculature. Now, there is a condition where in times where the heart needs more blood, the myocardium needs to increase the oxygen consumption, their microcirculation cannot dilate sufficiently and the resistance remain high in a way that doesn't allow the flow to increase sufficiently. And that is what we call coronary microvascular dysfunction. In other words, we get the inability of the microcirculation of the arterioles to really dilate sufficiently, and by that, the amount of blood that reaches the myocardium is not sufficient, and then we have ischemia. Now, the amount of times that the blood flow increases after the dilatation of the microcirculation, it can be quantified in something that we call CFR, which is basically maximum flow divided by resting flow. And CFR measures exactly the number of times that the flow increases, and a CFR of 3 basically means that the flow triples from baseline to hyperemia. Now, why is this important? Well, I'm showing you a case where there is a patient that has normal epicardial vessels, so normal angio, but now the patient on the left side of the slide has, let's say, less or no ischemia. On the right side of the slide, we have what we call INOCA, so ischemia in the absence of epicardial disease. And you see pretty clearly this subendocardial region of ischemia. And again, and this can be captured by a CFR or is due to a CFR less than 2.5. And now, with this in mind, we will start understanding why actually the ischemia develops at the region of the subendocardium. And basically, the explanation is pretty simple, and it requires that we use our clinical thinking. In the sense that is the endocardial part of the myocardium that is the more, let's say, vulnerable to ischemia. And the reason is because this is the region that is, again, also subject to the pressure inside the ventricle, and that, of course, will produce some sort of collapse at the level of the microcirculation, the subendocardial, and that is one of the reasons why we see subendocardial ischemia. And you can, of course, clinically speaking, understand how all the situations where you'll have high end diastolic pressure will basically be a contributing factor to development of subendocardial ischemia. And if you have absence of epicardial disease and you measure CFR to microvascular dysfunction. Now, the reason why this is clinically relevant is because if you measure CFR and the CFR is low, that patient will have 3 or 4 times higher chance or higher probability of dying or having an event in the follow-up. So this is a meta-analysis of more than 8,000 patients, basically demonstrating that CFR is extremely strong prognostic value in patients presented to the cath lab. And The reason why we use the cut of 2.5 come from different analysis, but this is one of the majors, basically showing that when you have a CFR that is less than 2.5, there is basically a change in the slope of the curve, showing that the risk of death and heart failure basically increases with the reduction of CFR less than 2.5. Now, there are different ways to measure CFR, and today we have bolus thermodilution, which is available in every cath lab with the use of the Cardiovascular machine. There is the Doppler, which is coming back. That's distributed by Philips. And there is continuous thermodilution, which is a combination of the Cardiovascular console together with what we call the ray flow catheter, which is an infusion catheter. I'm going to focus the presentation on bolus thermodilution because it's the more widely available and the one that I think it's already being performed in the Middle East. How does this work? Well, it's the principles are basically the same principles that we use for thermodilution in general when we do, for example, a Swan-Ganz measurement. But in this case, we're going to do it in the coronary. The pressure wire has also two places where the temperature is being recorded. So two thermistors, one in the proximal part of the wire and another one in the transition of the radiopaque part of the wire. And then the techniques require that we then place the wire in the distal part of the coronary. I'm going to play the video again. We place the wire in the distal part of the LAD, for example. And here you will see that we inject bolus of water. And every time that we inject water, we see a deflection in the temperature because the water is cooler than the blood. And that can again generate these deflections on the negative side. Then we just measure the time that it takes between the proximal and the distal deflection of temperature, and that we call that transit time. I'm going to come back to that in a second. Now, if we use these transit times, these are measurements, let's say, of surrogate of velocity of the blood, then we can use that as a measurement of flow. And if you remember the Ohm's law, which I showed you in the previous slide, we know that if we have the flow and if we have the pressure, we can calculate the resistance, which is why we're interested in. Remember the first slide when I show you that the amount of flow increase depends on the reduction of resistance. So if we can calculate the blood flow by basically taking the volume of the coronaries, dividing that by the velocity. So as we measured flow, liters per minute, milliliters per second, it doesn't matter. And this time we're going to take the mean transit time, which is again the time between the two deflections of the bolus thermodilution curve. And then we're going to use the inverse of that to assess as a metric of flow. And if we have flow and we have pressure, because pressure just measured with the wire, then you get a surrogate of resistance. And the resistance derived from this method that I'm explaining you is called IMR, which is basically the derivation of the flow based on the mean transit times and the use of the distal pressure that we measure in the coronary. And we end up with this formula, basically distal pressure times mean transit time, and we can calculate IMR. Now, clinically speaking, this is how it looks. So this is a screen where you see on the right side FFR on the top, then you see here the CFR and the IMR. And these lines that you see here are the three blue lines, are the mean transit times or the thermodilution curve in resting conditions. Then we accelerate the blood flow by inducing hyperemia. That can be done by adenosine, papaverine, nicorandil, exercise, you name it. Then you repeat the injections, and what you see here is the following. The resting time, which was the time that it took from that red blood cell to come from the ostium of the coronary to the distal part, was 0.8 seconds. Now, after hyperemia, becomes 0.26 seconds, and basically this leads to a CFR of 3, which is normal. Good. Now, this CFR derived from bolus thermodilution correlates well with the CFR, for example, derived from Doppler. And I have to mention that this CFR derived from thermodilution slightly overestimates the CFR derived from Doppler, but you see the correlation on the slide. I will not go into the details of the CFR derived from continuous and from bolus because we have recently determined that the correlation between these two is very, very low, and we're still understanding the clinical implications of this. Now, we talk about CFR, and I explain you how to derive IMR. Well, here we have then the validation of IMR. And IMR, again, is the index of microvascular resistance, which looks at how is the resistance of that microcirculation that will basically modulate the flow. And this is the first validation study, the animal model showing the true resistance here in the horizontal axis and the IMR in the vertical axis. And you see here there is a moderate correlation. Now, the real validation of IMR is clinical. And when we assess IMR, for example, in the context of myocardial infarction, we are faced with this information. So if in the context of a STEMI, you measure the resistance with IMR, if the resistance of IMR is high, then that will be associated with a reduction in survival. The same applies with elective PCI. If you measure IMR after an elective PCI and you look this series of stable patients, you see that patients with high IMR after the procedure, let's say, worse outcomes, both in terms of pre-procedural complications and also long-term outcomes compared to those that end the procedure with a normal IMR. Basically suggesting that having a problem of the microcirculation during the PCI, either during or after, it associates with worse outcomes. Now, of course, the holy grail, or where we really see a niche of these tools to be used, is in patients without obstructive CMD. And this is a typical case of a patient with CMD. You see here that the CFR is 2.2, the IMR is 37. That's a typical case of what we call low CFR with high IMR or structural CMD. The cutoff value of IMR, and we have to think about IMR as a continuous value. We like to use cutoff, but in this case, I think IMR is a continuous value. But I'll tell you the story that the reason why this was derived, the 25 as a cutoff was proposed, is because in a number of patients, we saw that none of the patients that have normal coronaries, very young, without any atherosclerosis, none of them had IMRs above this threshold. And that's the reason why that became the threshold. So there is no real hard threshold for us to say that this is the value. So again, you have to use a clinical rationale in order to make the appropriate diagnosis. So there is an association, but we should measure IMR and CFR in clinical practice. And that's the question that I think it's the most important one today. And I explain you these results of this study, which are quite interesting in the sense that when you start using these type of tools in patients that are referred to the lab with, let's say, a positive non-invasive test, you see here how the false positive rate starts to decrease. What does that mean? Well, it means that not so long ago, we used to say that, oh, that was a positive exercise test, that not seeing the coronaries are normal in the angio, you would have said that's a false positive. Well, not so fast. If you start then assessing CFR with adenosine, that false, you get a number of patients that have CMD, and that false positive rate decreases. And if you look further with acetylcholine testing, that number goes to 0. In other words, these false positive tests are not really false positive. We're doing not a complete assessment of the coronary circulation in the capillary. Now, perhaps the most important study is the one that I'm going to show you now, which is the CHAMP CMD study, which basically tested treatment strategies for patients with CMD. I will tell you what they did. They did CFR in all patients that had normal epicardial vessels with symptoms, but they did not show the results to anyone. And they gave medication, in this case, ranolazine and amlodipine, to all the patients. And only those with low CFR actually improved their exercise capacity in their angina, pointing to or suggesting that is not adequate, let's say, to start giving medications to everyone, because basically it's not necessary for the patient in the sense that they will not improve. So this tool then becomes essential to understand who are the patients that will benefit from treatment with medication. So in summary, I will say that CFR is a metric that has been extensively validated. It depends on both epicardial and microvascular disease, whereas IMRs is more specific of the microcirculation. It can be calculated, IMR and CFR, using bolus sample dilution. That takes, in my cath lab, 1-2 minutes. It's quite easy and it's quite fast. And we have already data support correlation with IMR in patients with ACS and after elective PCI. Thank you for your attention.